worked right away this time.
Snow just started, so it can't be stuck.
I wouldn't think so. There he is.
Pass it along. No.
Now the party can start.
Looks like it was starting.
We were delivered this morning. I was.
You were?
Whole world knows you
And
were.
it was bright sunshine
Well,
until after
good,
Silver
as it-
Bay, and all of a
as it
sudden we
should
went
be.
on the
Know the
corner and
truth,
it was
right?
this. Just like that. It's like, what happened?
I know.
Watching the
Well,
beautiful
we're
sunset over
supposed
the
to be
lake and
We're supposed to be the only place getting snow too, so.
Snow coming.
later in the lake, and then while they were talking about freezing rain.
Don't want that.
Snow and rain.
That's all you need,
What can we do?
day by day.
It's nice to have easy sunny driving for most of the way.
You almost said white instead of Svaleson.
I know, I did. You're not.
Yeah. Thank you.
Just dropped off the website. It just dropped off the website, the color changes. Strange.
We're good? Okay. All right. Good morning.
Good morning.
Welcome, everyone, to this Tuesday, February 15th, 2022.
I just noticed.
Our Public Health and Human Services Board. I'd like to call this meeting to order.
Oh, dear.
First item is the consent agenda, which includes our meeting agenda. So if anyone has anything that they'd like to change on the agenda, this would be the time.
Just a note on the introduction of new staff, Stacy Schmidt is unable to join us this morning, so a minor adjustment to our agenda this morning.
Okay. Thank you, Allison. Any other changes to the agenda from anyone? In which case, I would be open to a motion to approve the consent agenda.
Chair, I will motion to approve the consent agenda.
Thank you, Commissioner Svaleson. We have a motion. Is there support?
Support.
Thank you, Commissioner Storlie. Motion and support. Any further discussion? Hearing or seeing none. All in favor? Aye. Opposed, same sign. Motion passes unanimously. Thank you all. Moving on to item 3, introduction of new staff.
Thank you, Commissioner Mills and board members. Very excited to welcome 2 new members to the Public Health and Human Services team this morning. We have Christine Ordeman joining us as an eligibility specialist in the Economic Assistance and Healthcare team, and we have Savannah Capps joining us as the in-home support coordinator and adult services case manager on the adult and home and community-based services team. So we're really thrilled to have both of them on board and would welcome either the staff or supervisors if you want to say anything else you're welcome to, but we're just really glad to have you as a part of the PHHS team.
Yeah, thank you. And very, very fortunate to have you joining our team. I really appreciate it, and it's very difficult work, and so all the more thankful for the work that you do. I guess I'd like to give just a round of applause for joining the team. And if you do want to introduce yourselves at all any further, please feel free.
Since we're here.
Yeah.
I'm Christine Ordeman. I lived here on the North Shore for 13 years. Was previously a Luton Township Supervisor. Moved to Grand Marais about 3 years ago. And I'm excited to be on staff. It's my third week and so far so good.
Thank you.
Thank you.
Hi there, I'm Savannah Capps. I have been living in Grand Marais for about 2.5 years. I was born and raised in Florida before that, so big change, but I have an MBA degree, and then my bachelor's was in psychology with a minor in criminology, so I think I'm going to be well suited for the in-home support program. I'm hoping that I can make a big difference and improve that program.
Thank you. And thanks to you both. Welcome. Very, very lucky. And thank you, Allison, for the introductions there.
Absolutely. Thank you.
We can move on down to item 4, our COVID-19 situational update. I saw Grace locked in and is available, so I'll hand it over to Grace.
Oh, it's just a screen. She controls it. I get it. I'm so used to having I know, doing whatever I want to do. Your snowflakes too.
Hello, everyone.
Morning.
Nice to see you this morning. So, I don't have a PowerPoint today. I'm back to my normal notes, but I do have lots to share, as always. So, as of today, our case count is at 803. So at our meeting last month on January 18th, we were at 607, meaning it's gone up 196 cases in the past month. The previous month, our increase was 240. So we have seen our surge begin to slow down, which is welcome news. In terms of vaccination rate, we have 80.9% of the county fully vaccinated and 85.1% having received at least one dose of COVID-19 vaccine. We have also, at this point, 3 reported deaths in the county due to COVID-19, and that is up 2 in the past month. And finally, we are back up to being fully staffed in the public health department as of yesterday. So that is fantastic. Moving into our response activities, for contact tracing, we've been working hard to update all of our materials to reflect the updated CDC guidance on isolation and quarantine. That changed right around the new year. We continue to encourage people to call in their over-the-counter positive COVID-19 results. That helps us have a more accurate estimate of how much COVID is spreading in the community. And it also allows us the opportunity to provide isolation and quarantine guidelines for the people who've tested positive and their family members. We also, this past month, saw the availability of a new antiviral drug for COVID-19 called Paxlovid at Sawtooth Mountain Clinic, which is very exciting. It is in short supply, and it's limited to being available to a small group of higher risk individuals. So the role of public health in this has really been to help people connect up to that resource if they've had an over-the-counter positive. So if they've had an over-the-counter positive, we want to let them know that if they're interested, we'd be happy to pass their name and phone number on to a triage nurse at the clinic to let them do the assessment as to whether they'd be an appropriate candidate for this antiviral drug. The drug works best if it's taken very soon after symptom onset, so it's really an incentive for people to test. because if they take it later on in the course of illness, it doesn't work as well. So having that here in the community is wonderful news. It is effective against the Omicron variant, so it's good to have more tools in our toolbox. And we're happy to help make that connection for people to the clinic so that they're able to access any resource that might be available to them to fight the virus. We also have worked with schools as we saw an increase in cases on site at school in the new year to train in every school has a COVID-19 coordinator. So they've been helping take on more of the contact tracing calls for cases at school. And that's helped us manage the volume of cases that's come through in the past 2 months. We do continue to offer routine testing for COVID-19 on site at ISD 166 on Mondays. And then we also are working on Wednesday afternoons to offer routine testing to any staff or child in school or childcare anywhere in the community. So that program has been working well. We have every week had 1 or 2 positives coming through. So it is working to find people who are asymptomatic but positive and want to test because they work in or attend school or childcare where there is a high level of exposure just due to the nature of being in school or childcare. So that's been a successful program. We're exploring with the school leaders at all different schools. There's a CDC program called Test to Stay, and what it means is if a person is exposed at school, they're not up to date on COVID vaccinations, it's an option for them to test frequently after the exposure as an alternative to quarantine. So it's an attempt to balance in-school instruction so people aren't missing school multiple times due to exposures. But also that desire to lower the amount of virus spreading in the community by having them test frequently. So we're getting to a point where I think we have better access to over-the-counter tests, to testing on site, where we could work with the schools and actually make that a reality. And the end result would be fewer people out quarantining and hopefully continuing to control the spread of COVID on site. So that's very exciting. The schools do have better access to over-the-counter tests than the community at large. There's just some issues that are kind of in the supply chain that make it sometimes easier than other times to access those over-the-counter tests. But between public health and Sawtooth Mountain Clinic, we have been fairly well able to continue to have those tests available at the pharmacy. And the schools have their own kind of pathway to order for themselves. So there's still availability through schools. But we're working to keep it that way for the broader community. We also received and we also purchased some KN95s for kids with grant dollars through the North Shore Healthcare Foundation. And we also received adult-sized N95s through the state at no cost. And we're working to distribute those out. So the school ones are really important for kids who've been either exposed or recently returning from isolation, so they can wear a higher quality mask when they're at school and have access to that just at school. And so we've distributed those to the schools yesterday, and now we're working on the adult sizes. So we wanted to start with the kid sizes and then move to the broader community on that. So that's exciting. That's a project we've been working on that includes every little pack has 5 masks in it, an info sheet on how to use them and reuse them, and then actually some little lunch bags to actually store for reuse, the KN95. So that's great. I think that's been a gap because it's been a challenge to find places to buy those locally. So I think that'll be helpful. And the idea is we'd have kind of sites where people could pick them up throughout the county. So that project is in progress. We're also working on a video with our local healthcare voices. So it's a video that Matthew Baxley is working with us on to highlight the voices and experiences of local healthcare providers throughout the pandemic and give them a chance to let the community know what they would like to see in terms of helping to support our local healthcare system. So Matthew did interviews with healthcare workers in Grand Portage at Grand Portage Health Services, at Sawtooth Mountain Clinic, and at North Shore Health. And he's finishing up that short video in the next couple of weeks here. I'm also participating on a state COVID-19 response and recovery group representing the Northeast region of counties. That group started to meet last week. And it's an interesting group. I think it's trying to get regional representation and representation from a variety of sizes of counties as to how the public health system continues to respond and also move into the recovery phase for COVID-19 at some point. So happy to be a part of that and represent the Northeast region. And then finally, I feel like with the surge starting to kind of wind down, there's been this kind of outstanding question, which has been an outstanding question throughout the pandemic, of kind of what comes next with COVID. Like, when does it become endemic, which is a term I can kind of define here, but it's essentially what happens when we move out of the pandemic phase. What does that look like? What does that mean? And like with many things COVID related, I don't know if I have a great answer for you, but it is something that I think is on a lot of people's minds, so I think it's worth at least talking through a little bit. Basically, an endemic disease is a disease that's circulating at a less, it's still circulating throughout the world, it's not going away, but it's not as much of a roller coaster with these big surges that go up and they go down, and they're very unpredictable. Basically, enough of the population of the whole world has had COVID or been vaccinated or some combination of the two that it becomes less of a dynamic situation. So there's lots of infectious diseases that are endemic, diseases like measles or malaria, and public health does have a role in trying to keep tabs on how those diseases circulate throughout our communities and throughout the world. So COVID is not going away, but at some point it'll become less of a roller coaster. We'll still have people getting sick, we'll still have people hospitalized, and unfortunately we still will have people dying from COVID, but it won't be as dynamic a situation as it has been in the last 2 years. So we'll kind of find a way that we'll live with COVID as a society and as a world. So I don't think we're quite there. What I'm expecting to see in the coming weeks and months, I think we are entering a period where there'll be slightly less COVID than we saw at the beginning of 2022. But I think we're at a period where we're going to have to remain on high alert and expect that there's still going to be that fluctuation in case rates, where we might see a period of a few months where things calm down. And then we might, with very little notice, have another peak surge like we saw with Omicron, where we heard about Omicron and 6 weeks later we had more COVID activity than we had in the entire pandemic, and we had to just switch back into full-on response mode very, very quickly. And I think we have to be in that kind of ready state where we can very quickly scale up our response according to what we see happening with COVID. I think we don't know if there will be other variants that hit us as hard as Omicron did. There could be, but at this point we just don't know. So we have to be prepared and flexible and ready to scale up and respond accordingly. I think we can continue to expect vaccination to happen. We are still vaccinating Thursday afternoons every week at the community center. And I think at some point in the next few months here, we'll see vaccination for the under 5 group. I think we'll continue to see treatments like the antiviral treatment that I talked about becoming more available, and another powerful tool in our toolbox. And I think things like masking, testing, having good ventilation, they're not going away either, but I think that we'll become more used to scaling up and scaling back those interventions alongside what we see happening with COVID. So I know it's disappointing because people want to go back to normal. They want to be done. I understand that. I feel the same way a lot of the time. But I don't think that it's realistic to expect that that's what's going to happen in the next few months or even few years, to be honest with you. I think we're going to have to move to a place where we can teach people why the things we're asking them to do are important, and give them the tools and the knowledge to make informed decisions based on risk with COVID in this dynamic situation for the foreseeable future. So in some ways, I don't think our role with public health is going to change. We're still going to try to provide people with evidence-based information according to what we know in public health, and then access to things like masks, tests, and vaccines. So in some ways, things don't change, and in other ways, I think we have to be ready for this to continue to be a dynamic situation for the foreseeable future. And I think we also can't forget about the mental health impact of the pandemic and how challenging it is to continue to ask people to be flexible and ready to respond to a virus that's largely out of our control as humans. The things that we do make a difference, but we're not the ones driving the surges of COVID. We're making a difference with our behaviors, but we're ultimately kind of at the whims of the virus here. So I think I didn't want to end on kind of a doom and gloom note, but I think it's important to be honest with people as to where we're at. I think we've done amazing things as a community. I'm really proud of our vaccination rates, at how receptive the community has been to listening to information on things like masking, testing, talking to us when they test positive. So I think we have a lot to be grateful for and proud of, and I can understand the burnout and want to make sure that we're continuing to be honest with the public. So thank you for listening to my thoughts on the future. Unfortunately, I don't have a crystal ball, but I'm happy to share what I know and what I don't know with you all. And so happy to take questions as well. Commissioner Sullivan?
Grace, I know that this week tests are arriving that have been ordered through the government, coming through the U.S. mail, and there are lots of questions about at what temperature can those be sitting in a mailbox. And do you know anything about that temperature for those
I don't.
tests?
That's a good question. I don't know. Yeah, I know more for the saliva tests, but for the over-the-counter tests, I can look into it, but I'm not sure.
All right, if you could look into it, because I have had a couple of people call me and ask, and I have actually ordered those tests, and I'm aware they're coming, but don't know about that. So if you could get that information, that would be helpful. But they are arriving starting this week.
Mr. Storlie.
Thank you. Thank you, Grace, again for all your work and everybody in public health. I did get my kits the other day. I didn't get a notice about it, but then my neighbor did, that they were going to be arriving. It's kind of like, okay, there's kind of doesn't matter if there's a conflict. I got them, they're getting them, that's okay. But there's a lot of kits out there. I saw them in the grocery store for $10.95. I saw them at Walgreens for $24.95. They're all the same though, right? It's all basically the same.
The basic idea is the same. So they look for that spike protein, the antigen, and then if it's present, then it registers a positive result. But some of them, I mean, they all work in slightly different ways. Like the one that they've most commonly given out through the schools, you have to use an app on your phone for example, and other one. But I mean, the basic technology is the same. They just kind of package it in different ways.
Okay. The KN95 masks, are they available at the clinic or anywhere in town?
They're available at the clinic right now, so we're hoping to pack up enough so that we can have more drop sites throughout the community, but they're available at the clinic and then they're available at the schools right now for kids in school.
Okay, and is that the little kit you were talking about? Okay.
Yeah.
And is there a cost to that?
Nope, those are free.
Okay. And do you think, looking out into the future, that that another booster perhaps is down the line a ways?
I'm not sure. I mean, I think that they're working on technology for vaccines that could be responsive to a variant perhaps that would evade some of the protections that our vaccines and treatments have allowed us in the past. I'm not sure if it'll be something that is kind of like a flu shot that's like recommended on an annual basis. I don't think that we'll continue to see a booster, every 4 to 6 months forever, but I think I could imagine a time where we're seeing once a year kind of COVID-19 vaccines similar to what we see for the flu. But I'm not sure.
To be determined.
Mm-hmm.
Thank you.
Mr. Yorkie.
Thank you. Thanks for that report, Grace. Quick question. So when I hear the case count, my mind always goes to what percentage of our total population that represents. But I'm guessing that some of those cases are people who've been diagnosed more than once. Is that true?
Yes, there are repeat infections.
Okay.
I don't have a firm sense of how many it is, but one of the things with Omicron is that it evaded, typically, I guess we'll say, we were seeing protection from previous infection for up to 3 months. Mm-hmm. But around the time we switched from having Delta to Omicron as the predominant variant, we saw people who were more recently infected with COVID becoming infected again within less than 3 months. So, yes, there are people who've been infected multiple times.
Mm-hmm.
I don't know how many, but yes.
Okay.
I got Andrea Orist is listening in and sent the updated answer to Commissioner Storlie's question. So that the test temperature guidance, at-home rapid tests should continue to work if they're left out in freezing temperatures for a short period of time. Bringing the test back to room temperature for at least 2 hours should make it usable. But heat exposure may damage it beyond use. I don't think that's an issue for us right now. If you have any doubts, if the control line on the test looks normal, then it should be working. And if it doesn't appear normally, then the test is defective. So usually there's 2 lines, a control line and then a line for if it's positive. So I guess that's...
Thank you.
Yeah. No problem.
Thank you, Andrea.
Yeah, thank you, Andrea.
I don't know if anybody's done a testing. Have
Yeah.
you done home kit? And I had to do it because I was going to a seminar and they required it. And I was glad, But I was just scared, read all the instructions, put the little cup here, put the swab in there, do this. Oh dear, please, no. And it wasn't, but
Yeah, it
Your
kind of
first
feels
time
like
around, you're
a
just
home
so
laboratory
nervous.
that you're
Yeah.
setting up.
But then you took a picture of it with your phone, and that's how you submitted it when you came to the seminar. It was really slick, Then somebody said, well, somebody else could have done that for you. It's like, no, let's hope we're all honest about stuff,
Really?
Yeah, so it did work well.
Yeah, it's interesting, just in a lot of conversations, how different minds work. Some people go the suspicious tact, and other people go well, we're all trying to get through this,
Right.
sort of tact. So I think that's part of the challenge that we're all struggling with, is just trying to keep on that team mentality and that collaborative side of things versus kind of getting pretty fractured and going down lots of rabbit holes. So, Grace, I'm very grateful for obviously all of your work, but and then during this, still significant time of infection, moving on to that recovery planning, because that is going to be a major undertaking, and just how to go about that seems just really daunting, and especially not even knowing. I mean, to some extent, we need to start it now, right? Like we're
Right.
trying to recover from this trauma that we've all felt as a society, but then there's the actual post, if that's a thing.
Yeah, it's much different from the traditional emergency where there was like a well-defined beginning and end.
Right.
I think that's part of the challenge.
Yeah. Yeah, and just how, like you said, just how mental health is going to play into everything with that too, because there's the physical aspects of COVID, and then, I hear reports about the mental effects of COVID, but then there's just the mental effects of this trauma on everybody, and so there's just many layers to it, and as time goes on, I suspect we'll understand a little bit better and find more strategies how to deal. But I'm just really grateful for any efforts that you can add on that front, knowing how much you already have going on, so.
I think it's
Thank
one
you.
of the things I'm grateful for being in the integrated department with PHHS, that there are other staff within the department that have much more expertise in supporting mental health than, and it's great to be able to work together on those types of efforts and look forward to continuing those. And one other piece that I haven't spoken much about, but is also on my radar, is the impacts of long COVID overall. There's a lot we don't understand about the cases of who recover from COVID in its acute kind of infectious state, but then have lingering symptoms for weeks and months afterwards that really interfere with their ability to work and just have normal day-to-day lives. So I think that's going to be another major challenge for the healthcare system and society going forward. I know there's some research in that area, but it's an area I would anticipate learning and hearing much more about in the future.
Yeah, I keep my ear open to it for the region and national news. Do you have much anecdotal stories about that locally?
I mean, I do know that there are people, it's something that we don't have comprehensive data on, how many people locally are suffering from long COVID symptoms and what's available to them in terms of treatments. But, I think the estimates range from, 10% to 50%, which is a huge range. And so I think at this point, it's just hard to make any sort of generalizations as to what it might look like and how it might affect people. But anecdotally, yes, I know that there are people in the community who are suffering from long COVID symptoms, and I don't know how many.
Oh. Yeah, I just haven't heard much. I haven't heard much from people locally around that topic. So the more we know, the better. Well, thank you very much. And yeah, it's not just Grace. It is the whole department. It's the whole team. It's the whole community working on this. So got a heck of a department. Thank you very much for your work there. And any other questions for Grace at this time? All right.
Thank you.
Thank you. And that moves us on to item 5, staff report. And today we have a report with Case Management Services for People with Developmental or Intellectual Disability with Julie Kinney.
Hello.
Good morning.
Good morning. Can you guys hear me?
Yes.
Yes, we can.
Okay. So I've done this presentation before a couple of different ways. I think the last time I had it, we had a guest speaker come, and one of the individuals that I work with, and he talked about his work in the community. But I see a lot of new faces here, so I think I'm just going to kind of go back to the beginning and introduce myself and just kind of talk about what I do real briefly, because I think you all got a copy of this, so I'll just kind of go through a couple of the bullet points and then open it up for, I think, more general conversation. So I've been in this position for 8 years here, working at the county with individuals who have intellectual and developmental disabilities. I also wear a couple of different hats, but that's my primary role is doing waiver case management for both DD is kind of the acronym that we use, and also CADI, and thank you, Martina, for including the definition in here. I also do CADI waiver case management, but I'm not the primary case manager, so I work fairly closely with the children's mental health worker on the unit with those individuals. So the people that I work with both kids and adults, the whole age range. In some of the bigger counties, those are separated to children's developmental disabilities and adults. But here in this county, because we're such a small county, I do both. And 8 of the individuals that I work with, is that right? 8 out of the 20 live out of the county. So the reason for that is we don't have any 245D licensed facilities in Cook County. And that's the license that oversees the DD population. So when we have individuals who have higher needs that can be met in this community, the result is that they ultimately have to move out of the community and into communities that provide these services. But we remain the county of financial responsibility and also case management. So then what I do is travel some of the time, pre-COVID, travel to meet with them on at least twice a year, if not more, just to do kind of annual meetings and touch base and check in with them. So since COVID has happened, I've been doing a lot of those meetings, just through telephone or through, Zoom teleconference meetings, which has been really difficult because we all know, kind of how awkward they can be. And it's especially difficult for a lot of the individuals that I work with who might struggle with communication issues as well. So that part has been particularly difficult during this time. And I think I'm just going to kind of leave it at that, and I'm just going to open it up to questions. Or comments.
Another one of the challenges that we've experienced with COVID and not being able to see people face to face is we've noticed in our people who live in larger communities and maybe we're accessing more services in the community prior to COVID. Because of COVID, their ability to engage in those services, like going to a day program, is limited. And so where they might have had more eyes on them throughout the days or weeks, they're now having less people that they're interacting with. And we're helping someone through a situation where in the past, some of the things they're experiencing, like their healthcare is not being managed well from our perspective. They live in a place where the staff is supposed to provide healthcare and provide supervision. That was all taking place just fine prior to COVID, and now that there's less eyes on, there's staffing issues, we're seeing some changes with this particular person, and that's one of the detriments of COVID, that we can't be as out there as we would like, and we also, our clients can't be as engaged in the community as they had previously. And as much as we can, we really try to help our clients to be integrated into the community, taking part in activities, because it's so worthwhile for them to be able to do that. And with COVID, that's really been a collateral damage that we've seen. So just wanted to give that sort of effect that COVID has had on Julie's caseload. It's also more difficult for her to find placement for people. So if someone is wanting to move out of the community and move into a place where they can learn independent living skills and gain employment in the community, there's waiting lists. It's harder to get someone to that level of service. So those are just some of the changes that she's helped people with during the last year or so, 2 years actually.
And there's waiting lists because of the staffing shortages as well, and that's a huge piece statewide. So there's staffing shortages up here in Cook County, but with this particular individual, there's staffing shortages, and and so the care becomes questionable and the wait lists grow longer. And in the meantime, individuals are struggling and having mental health struggles. But in order to be able to help them, we have to put them in facilities that are fully staffed, and that's not an option right now. And so it really is a struggle right now. And I know it's, everyone's kind of going through the same thing, but it's just really seeing kind of that trickle-down effect from COVID has been, heartbreaking in some cases, especially with this particular person that we're working with. It's hard to watch, and I feel a little helpless up here behind my computer screen. So, yes.
Julie, a question I have is, even prior to COVID, we've had young people that have been placed out of the county, and it's extremely difficult for them to interact with their families and friends. What is the reason that we don't have a facility here in Cook County?
I think part of it is there's a lot of, it's a lot to become a licensed provider. A 245D licensed provider. It's a lot of work, it's a lot of red tape, it's a lot of training, and then it's the staffing issue. So, finding a property up here to, to turn into a facility or to build one, that's more expensive up here in Cook County, and then hiring staff and retaining staff. So those are just some of the issues, but the bigger overall issue is that there's a moratorium right now statewide on opening new 245D facilities. Community residential services is what they're called now. They used to be called corporate adult foster care. So actually, since I started 8 years ago, there's been a moratorium. So really the push is moving individuals out of, these facilities and into the community, and providing wraparound services to help them in their home, so they can be as inclusive as possible in the community, which is a great idea, but sometimes it doesn't work up, especially up here, because sometimes people just need a higher level of services, and a lot of times up here, there just isn't the staffing to help them. Some people might need not necessarily 24-hour care, but care for a good portion of the time, and so finding 2 or 3 people to work several different shifts, coming into the home for for that time is, it's pretty difficult up here.
Thank you.
Mm-hmm.
Mr. Yorkie.
Yes, thank you, Julie, for that report, and Martina for the information, too. My question is for, you mentioned that there are 8 Cook County residents who have been placed out of the county.
Yep.
Are those just adults, or adults and children both?
Just adults.
Okay.
At this point. I've only had one child who was placed out of the county, and actually that happened prior to when I was hired. So then when I was working with him, he turned 18. And so I haven't placed any kids outside of the county.
Mm-hmm.
And I've actually only placed one person. So they were already in place when I came on board. So historically, right now, the kids that I'm having age out is what it's calling, aging out of the kind of the children's system. Mm-hmm. The majority of them are remaining up here in Cook County and living with their parents or their relatives or their guardian, whatever their living situation might be. Mm-hmm. But again, it's difficult for those families, because then they become the primary caregiver, because it's hard to hire staffing, and because the funding is there to be able to support that, but the manpower isn't, or the woman power isn't there.
And so for the folks who are placed out of county, how does that affect the families in terms of their ability to see their loved one? I mean, are they being placed like mainly in Lake County, or is it even further away than that? How does that look?
I have individuals in Aiken, Duluth, Hennepin County, St. Louis County, yep.
Is it Ramsey or is it you said
Hennepin, yep.
Yeah.
I think that covers it. I used to have
Wow.
somebody in Grand Rapids. So, my person who lives down in the cities, her relatives are all in that area.
Gotcha.
So, it's just me who's way up here. You know, so for her, that's fine. And my individuals in Aiken, their mother lives, their guardian lives close to them. So it seems like the core families have moved, or are no longer living, you know, or sometimes they're not in the picture as well. So, but it is a struggle. You know, I know someone who was placed out of county. It is a struggle for the parents, but I also think that they see the skills that they're gaining and their level of independence and their inclusion in the community and their ability to, you know, obtain a job and maintain a job, and just the pride that they're getting from that. I think it's helpful for them to be able to see, you know, them kind of spread their wings a little bit and learn some new skills. So, so I think in that sense, it's probably pretty close to what, you know, parents feel like, you know, when their child leaves the nest. So, you know, those same worries, but also that same level of, you know, pride that they're learning new skills and that their, you know, their growth is continuing.
Well, and it's good to hear that they do have, in many cases, family members nearby. That was my main concern.
Yeah, yep.
Great.
Yeah, Pat.
Is there any relationship, Julie, between the services the people need who stay in county and our senior population or our elder population? Or are the services totally different that public health supplies?
Marty can help me out with this a little bit. So the services that the individuals that I serve receive are waivered services, and traditionally in the larger counties, either the case manager can kind of set up the services, the more formal types of services, and that's traditional waiver case management, or they can do more consumer directed. And because we don't have any 245D facilities up here, they're basically given a budget based on their needs, which is based on the assessment that we do with them. And so then with this budget, they purchase the services. So whether that's ramps in order to make their housing more accessible, or widening doorways for individuals who have mobility issues, or hiring support staff, or other like adaptive type of equipment, weighted vests and blankets, those types of things. So they receive kind of a waiver budget that they then kind of map out their spending for a year. I don't work too much with the elderly population that doesn't have developmental disabilities, so I don't know, Marty, maybe you can speak to that?
Yeah, so the services that we would see overlap in would be very minimal. So like the in-home support homemaking, we do have some younger clients on Julie's caseload, adults, but young adults that might utilize homemaking services. Transportation might be one that they could utilize. Sorry.
Could I move mine?
But what we really see the need for the population that Julie works with is independent living skills, help with gaining employment, and those are the services that we don't have in Cook County. So there are opportunities for this population to utilize some of those elder services, but it's pretty minimal where there would be overlap.
Did that answer the question?
Yes, thank you.
Okay.
I was just wondering if a bigger pool would generate more resources for the county overall, more budget money, whatever. Thank you.
Any other questions for Julie? I was wondering just about 245D facilities themselves, the structure, the format. Are they some basically single-family homes, others apartment complexes or communal living situations, or is it like a care center wing, or, you know?
Yeah, and it's actually not just specific to housing. It's any kind of program that works with individuals who have intellectual or developmental disabilities. So day treatment and habilitation programs are 245D regulated. Corporate adult foster care, supportive employment agencies where they just, focus on employment. So they all kind of fall under the 245D umbrella. So, but specific to housing, so the individuals that I work with, they're all living in the community in houses. And typically, a community residential service, they'll max out at 4 persons living in the house. I do have one that is licensed for 5. So they're licensed through the licensing agency at the county that they live in. So yeah, they're all living in, great houses, right out in the community with the next door neighbors. And so I don't have anybody who's living in an institution. And that has been the big push from DHS, is to move individuals away from the institutions and, to live more in the community. And now the push is to, because they feel that even though they're living, they meaning DHS, their thinking is that, even though they're living in a house in the community, they're still living with individuals who have developmental disabilities. And so it's not as inclusive as maybe living in the community with other individuals who don't necessarily have that disability or the diagnosis. So really the push coming down from the state is to be as inclusive as possible.
I suppose that varies community by community, just how much inclusivity there is, in a really tight-knit community or neighborhood. You could have that maybe easier versus, the big city or whatever sometimes. So.
Yeah, where we've seen a really great model is actually in Babbitt-Ely area, because they have, their housing is way more affordable, and so this company called Rural Living Environments has been able to purchase houses where they have people live, and they bring in the support, and they help people gain those independent living skills to where they eventually move into their own apartment. So it's, the key really is, a community that has that affordable housing, that these agencies can start building the services then. If you have, if you can't afford a place to even start, it's not going to go anywhere.
Right.
Yeah, it was, when I first started, I moved one of my individuals from into the Babbitt-Ely area and into one of these houses. So he went from living in a community residential center to renting his house and having a roommate. So when we pulled up, the staff came out and helped him move, and they said, well, here's your keys. And he was just like, he had never had a set of keys before to his own place, and just the look on his face was pretty priceless. So, and he is thriving there. He just got engaged.
Oh,
Oh, nice.
to his fiance. It was like, oh,
That's
Our boy's all
wonderful.
grown up.
That's wonderful. Okay, well, thank you very much for taking time today and presenting to us and having good conversation.
Yeah, you're welcome. I'm open to any other questions that you might have at all.
Yeah, well, we know where to send them if we got them.
All right.
Thanks.
All right. Thank you so much.
Thank you so much.
Thank you.
And this moves us on to item 6 on our agenda, the director's report.
Thank you, Julie and Martina, for your great report and conversation and stories today. Really appreciate you taking the time to join us. And I'm going to try and project my presentation here remotely. We'll see how this works. So some visuals to help guide my conversation. Looks like it's going to work. All right. Okay. Is that coming through on your screens? Or is that too much to ask of the
actually not.
technology?
It's
Okay.
not, but
I'm going to turn this a little bit, if that helps.
Oh, because that tablet, I bet.
I think it's hardwired, yeah, so I
Yeah.
don't know if my remote connection will work. But thank you, Administrator Yorkie, for making that viewable by our
Yeah,
board.
no, I'm good.
yeah.
Perfect.
All right, so starting as always with staff updates. We have welcomed a couple of new staff since our last board meeting. You met Christine and Savannah this morning. Just thrilled to have them joining the department and having those key roles filled so that can lift some of the burden off of our other team members. In addition to Christine and Savannah, we have, as Grace mentioned this morning, also been onboarding 2 temporary public health staff members who are backfilling that 20 hours a week that was filled previously by Andrea Tofty in her temporary part-time role. Andrea is taking the school COVID-19 testing pilot with her to her new position, her permanent position with the county, and Abby Benusa and Maggie Farchman are, between the 2 of them, backfilling that 20 hours a week, both in outreach, assisting with education materials, and case investigation contact tracing as well. That leaves us with just 1 vacancy in adult services. That posting closed last Friday, and we received a list of referred candidates late in the day yesterday. So we'll begin going through that, seeing if we have new applicants to consider reaching out for interviews and hopefully filling that position soon. We also have an additional vacancy anticipated this spring with the planned retirement of one of our adult services social workers. And just given the time frame for filling these positions over the last several months, we will be posting that in the next month just to ensure that we're able to bring someone on board, have time for cross-training, and not have another significant gap in those positions. The individual who's retiring has a rather large caseload, so we want to minimize any impact on staff and people served by having some continuity in that position. We will also be posting for the mental health practitioner position that is on our items for board action today. This was included in the 2022 PHHS department staffing budget. That posting is contingent on review of the job description by the Personnel Committee and scoring of the job description by the Job Evaluation Committee. We're fairly confident in what we have budgeted for that position, as it's quite comparable to the community support position that was previously filled by Matthew Baxley. It's a similar practitioner level, bachelor's level position of providing direct community-based mental health supports. I'll say more about this position and our ongoing efforts to address the gaps in behavioral health services later on in my report. Also under items for board action, wanted to provide a bit of an overview of a request that we received this fall from a employee within the department for tuition reimbursement, wondering if we have a policy as county government for allowing any financial assistance or reimbursement for training that is not specifically assigned to that employee as a part of their mandated coursework or training for onboarding into a new position. We do have a policy within the employee handbook on training reimbursement. I included the language from that policy in items for board action. The policy is limited, however, it doesn't have clear guidance other than the board will consider such requests on a case-by-case basis. So this is on James's radar and Leah's as it relates to developing clear policy guidance for the future, but wanted to honor these requests that were made in the fall as we do have a policy in place and bring those forward for board consideration this morning. Both of the courses are highly relevant to the employees' positions within the department, and our recommendation in consultation with the staff and supervisors is to grant partial reimbursement for those courses and the expenses that were incurred in 2021 while we move forward with clear policy and guidance on future reimbursements. I'll pause there to see if there are any questions on staff updates before I move forward.
And Allison, if I could jump in, I just wanted to say a few words about the request for tuition reimbursement. I know when I interviewed for this position, we had discussion about the importance of professional development. In my view, it's something that really the organization needs to invest in because it helps us build capacity. It helps us, helps staff become better at their jobs. It gives them the knowledge they need to be more effective in their roles. And I feel like this is something that is really important. And so in our conversations about this, I feel really supportive about taking this step. And I do believe we do need clear policy. I would like to see us be able to do this more broadly. We currently do, department by department, we do offer training that is reimbursed for different things. In the assessor's department, for example, they have to be credentialed, and so we have resources that we apply to get people credentialed. I think other departments should have the same opportunities for expanding employee skill sets and building their knowledge base. And so I strongly support this proposal.
Thank you.
And we will work on a policy that more clearly defines how to handle this in the future, because there is some ambiguity right now that makes it a little harder for department directors to know exactly what the parameters are, and so those need to be better defined.
Yeah, and I had the opportunity to attend some of the AMC leadership training, and I'd highly recommend those training sessions as well for all of us, commissioners and department heads for that matter. But one of the biggest ways to show appreciation for staff and to retain staff is just to keep that continuation and that support for learning and developing. And you know, I've heard criticisms in the past of like, well, why do they get that, you know, or the individual gets that? But the way, and you couldn't look at it that way. The way I look at it, though, is what do we get as well, as an organization, as a community? If we're having staffing issues, and we want to, you know, grow our own and support our own, this is one area that we can do that, and I just think it's really powerful. So I'd like to encourage it as much as possible. And you know, there could be the risk of people taking advantage of it, but again, I feel like that's reinvesting in our community. So I can't see it getting out of hand, although I think it's important to have a clear policy to ensure that. So I really appreciate your willingness to work on that, and I really appreciate you bringing it forward for us to consider, because yeah, it's an excellent step forward, I think.
And, you know, I'm not sure taking advantage, I mean, I'm not sure how that might look, but,
right.
You know, there has to be an alignment between the topic of study and the job. And I guess maybe what you're getting to is there's always a possibility that if you give people new skills, it makes them more marketable.
Yep.
And so maybe they don't stay with the organization. That's always a risk. I
Yep.
don't think that's a good reason
No.
not to invest in your staff.
No, that's, yeah, and I guess my point I was trying to get to is that it's in our, I'd hope it stays in our community, if not in our organization, but it's, we're all working to the betterment of all of that, so. Any other questions for Allison on this portion, or comments? Commissioner Hawkins?
Well, I guess, are we discussing this issue now, or, because I had it under the actual motion, so.
Oh,
I'm just,
we can
want to make sure I understand what's appropriate for me to,
well, we're not.
when it's appropriate for me to give my opinion.
It's always appropriate for you to give your opinion. Right now, we're not taking action, we're in discussions, and it was brought up, the training reimbursement in the staff updates, but then, I don't know if you want to go through agency updates, and then the health services, and then, but.
Yeah,
thank-
no,
You should ask now, and then we can also, process that, your questions, so.
Okay, well, I also support staff training and education, think it's extremely important, and I also am concerned we don't have a clear policy, and we're going back. We're approving something and saying, well, other people can get it later. Well, our policy might not allow that. I mean, how many employees do we have? Are we going to give every employee the opportunity for $1,000?
I hope so.
Where is that coming from? In budget, because we don't have it. We haven't budgeted. So I did do some research on this, and other counties are doing this, other businesses are doing it. I think it's something we seriously need to look at to keep our staff and to get new staff. I do think it's a good idea. I am just concerned that we don't have a clear written policy yet of how this will be applied. Other counties require pre-approval before the reimbursement. Some say you have to get a certain grade to get reimbursement, or it's a percentage. And that if you do leave employment, a certain percentage of that you have to stay, whether it's 2 years or 5 years, or you have to pay back part of that. So these are all things I think we need to discuss, and we need to have a policy before we say 2 employees can get this, and everybody else, you're just going to have to wait until we get a policy. Because I do know we have other employees here going for higher education courses right now.
Mm-hmm.
So I see this coming before us again soon, and I hate to set a precedent that we have to have this right now. I am not saying don't do this. I'm saying let's think it through a little bit longer and make sure we're doing it the right way. So, and also, okay, so I do have some questions. Okay, I found that one out. Do you know if this is a taxable fringe benefit?
I don't know the answer to that. That's a Brady question.
That would be an important thing. I did check the IRS website, and there is a educational assistance program, but it states it must be written policy and meet certain requirements. I read through the requirements. I don't know. Do we meet that? If we don't, it's a taxable fringe benefit. You can't go back. Payroll for 2021 is already closed. We're going to cause some issues with our payroll department if we find out, no, that needed to be run through payroll and not just a check written out.
Yeah. And
So-
Commissioner, I agree, that question needs to be answered before we do
Right.
anything further.
And I also have an issue with this new way of spending coming before this board rather than our county board. If you go back and read the employee handbook, it says these requests will be considered on a case-by-case basis by the Cook County Board. This is not the Cook County Board, this is the Cook County Public Health and Human Services Board. And I don't think it's a responsible position for our taxpayers when this board can make funding, spending decisions that haven't been approved by the elected official board. So those are my comments.
Thank you. Those are very good. And yeah, it sounds like we have a little bit more homework to do for the board action items. But Administrator Yorkie, you wanted to say something?
Mr. Chair, I just wanted to say, Commissioner Hawkins, I completely agree with you on the details of the policy that you're describing. You're right. I mean, most jurisdictions that have policies on educational reimbursement do have stipulations about minimum grade and about, if somebody leaves within some period of having gotten that training, then perhaps they refund part of the benefit they received. Those would be good things to include, and I think I agree, we need a policy that speaks to those issues. I also feel like, this is aligned. The payroll questions, the tax questions that you raised, we need to answer those. But in principle, I think this is a good thing to do. I think we should be supporting staff in this way. And I also think, the language in the HR policy handbook seems to predate the administrative form of government. And I think the way this should work ordinarily is that the departments would budget for professional development, and the board would approve that budget, and then it would be up to the department director and the administrator to coordinate to allocate those resources in an equitable way. To me, that seems like a more typical way of handling that kind of thing. I think that's how other local governments do that. So I think there's a risk of having the board overseeing the minutia of daily operations that probably doesn't make sense in this situation. I think if we budget for professional development, we have an educational reimbursement policy, those things can be managed at the administrative level.
One thought that came to mind just as far as that tax question is concerned, we definitely need to get that answered, but I don't think it would go on 2021's income, right?
The request is to make it go back in the budget to 2021.
Oh, I see what you're saying. Okay.
Which would mean it would need to.
Sure. Yep. That's a good point. Yeah. Pat, please.
Did you say there was precedent, though, Allison? Has someone else received this in the past?
Not to my knowledge. Speaking from my personal experience, I received time and accommodations to pursue my graduate degree while I was also working. I think that, we do have a policy in the handbook. It's just limited in its scope and guidance. I agree that there are a lot of factors that we need to clear up to ensure that it's applied equitably and that we're communicating about this benefit to staff. But again, wanted to honor the requests that were made and the fact that we do have unspent training and travel funds in our 2021 budget. It's a small portion of reimbursement in the context of a larger department budget, and I think, as we heard from many of you, really important to contribute to ongoing professional development of our staff, especially considering the current and looming staffing shortages and workforce challenges.
Commissioner Storlie.
Thank you. Well, since you have money already in the 21 budget, and by the time we get all of this revised, maybe it'll be like the end of 22, going into 23. So you could go ahead with 21. Then you have the money, you say, for a small amount of people doing this for this year. Do you anticipate a lot?
I don't,
Okay.
no. And I did get a comment from our fiscal supervisor, Lori Erickson, who is also tuned into the meeting, to say that, yes, the funds would be coming out of our 2021 budget, but the employee would not have received it in 2021. So it would not be on their W-2. It wouldn't have payroll tax implications because they're receiving that reimbursement in 2022.
Yeah, okay. And that's kind of what I was thinking, but then I had doubts, so appreciate clarification there. Commissioner Hawkins, you had
Yeah, I have one more question. So are these two employees currently enrolled in these classes, or have they finished these classes?
I believe that both of these employees have finished their course, but they are both still enrolled in higher education programs.
And, okay, one more.
Please, yeah.
Realize I didn't write this one down. So higher ed offers 3 scholarship programs. Did these employees go through higher ed to apply for scholarships?
I'm not aware of that, but that's one of the questions that needs to be worked out in developing clearer policy, is how this type of reimbursement interacts with other forms of financial aid and assistance, both on the employee and employer end.
Yeah, in my mind, not that we're getting into it now, maybe we are getting into it now. In my mind, that's less of a factor for some reason, and I don't know why. It's important to understand the comprehensive picture, but I just want to encourage development, straight up.
And with the cost of higher education, I think anyone who's going through higher education right now needs to have a portfolio of support. It's just not Cook County Higher Ed, or it's just not Cook County. I mean, there's a whole lot of money that's involved in doing these graduate courses. And so they probably need to look at all of them in order to make this happen.
Yeah, the more options, the better there. Yeah. I saw some other hands or fingers or something. Movement. I saw movement.
I was going to say something, but it just flew out.
Gone. I could come back. Luckily, we're not even at that item for action yet, so well,
It was me that I was trying to decide, should I say this now? But I will just let you know that at our Highway Advisory Committee meeting, I guess it was almost 2 months ago now, there is a serious, or there was a change, federal government change, rule change about CDL licenses.
Mm-hmm.
Potentially could have a huge impact on our trucking population and drivers, and it could seriously, potentially affect our highway department. Mm-hmm. So there we go, because they're going to increase the costs. So this is where I'm seeing, well, potentially this, if we do set this policy, I can see it being spent.
Mm-hmm.
Not a bad thing. What I'm saying is, we haven't budgeted for it. And it's unfair if we decide, no, you know what, we can't afford $1,000 for each one. We're only going to give $500 or whatever we would decide how we make that work. I think it's important not to reward just because they got their, I guess the other issue I had was hearing that this request came last fall, and here we are February. Well, I think if this request, if we thought it was valid or good, we should have received it back then and not backdate. I don't like the backdating thing. If we think it's important, it should be in our current budget. We use current funds to make it happen. So,
and I'm going to own that. That's on me, because Allison did bring this up some back in the fall. And it was something that I put on the back burner because there were many other things going on.
Totally
So I apologize for that. But the other thing that I was going to say is that in places, in local governments that provide educational reimbursement, there's a finite line item, obviously, in the budget. And frequently, it's just first come, first served. So if you have a policy that says, here are the conditions under which employees can be reimbursed, people know up front that if they're going to try to get to be reimbursed, that they need to get their request in early, that there's fair consideration up front for anybody who thinks they're going to be incurring educational expenses, and that there's an equitable way of distributing those finite resources. And that's why I was saying I think it's appropriate for that to occur at kind of the department director and administrative level, because if the budget is already approved for those kinds of expenses, we shouldn't have to trouble the board with the details of how those get allocated. It should just be, we strive to allocate them in an equitable way. So. And the policy can speak to that.
Yeah. Oh, I'm sorry. Thank
An
you.
additional comment to Commissioner Hawkins' point about budgeting is that we do budget for travel and training for our staff each year. Unanticipated effect of the pandemic again in 2021 is that staff weren't able to travel to attend trainings and conferences out of town to the same extent that they were in previous years with the Omicron surge mid-year and in the fall. So that impacted our spending, which is why we do have these unspent dollars in the 2021 department budget and the ability to consider these requests for reimbursement that were made in 2021.
All right. Well, good discussion. We're not through your report yet, are we? We still, well, that was just the staff updates, right?
Yeah, it was just the staff updates.
Yep. So let's move on, I guess, to item B, agency updates, if we may.
Okay. So quickly, a few updates on things that are going on within the Public Health and Human Services Department. We received the grant contract from the Minnesota Department of Health for our Healthy Housing Grant. That was a competitive grant proposal that we applied for last year to have one of our public health educators go through training with the Minnesota Department of Health to be able to conduct home-based assessments to help people who are living in potentially unsafe situations purchase and get education on modifications that could improve safety in their home. So Andrea Orist is taking a lead with that. We'll be going through the training. We'll also have cross-training with Andrea Tofty and Grace. And more to come in terms of outreach on how to make that program known and promoted within the community. Another major initiative underway is the request for proposals for managed care plans for next year. The health plans for seniors, people enrolled in special needs basic care, and prepaid medical assistance for families. Are all upcoming. These are day-long review processes with counties across the state and staff from the Department of Human Services participating, listening to information from the health plans and what they're proposing, how they're proposing to improve access, member benefits, and such for 2023. This is a significant time commitment for our staff, not something that we have a lot of capacity to participate in, but I am planning to be involved on behalf of Cook County and offer input on what we would like to see going forward. We have had the process delayed the last 2 years for a variety of reasons. There was some lawsuits about the process in previous years, so a lot of time has gone into engagement with counties on how to improve this for 2023, and we're hopeful that we'll see some changes going forward in how the information is used to inform that evaluation process. Wanted to give an update on the Tribal County and DHS Leadership Forum that I've been participating in. We had our first meeting in several months yesterday afternoon, so it was good to reconvene with that group. A number of the participants, and as a reminder to the board, this is a group that is comprised of leadership both at a state level from the Department of Human Services, a number of commissioners, assistant commissioners, staff from tribal nations who are working in human services programs, and county human services leaders as well. One of the initiatives that they were supporting was the Tribal County Relations training that a number of you participated in last week. A number of the participants on the forum were also involved in that. Much of our work to date has been on that relationship building mutual understanding of how governments interact in supporting human service recipients in our communities. A lot of context setting for various areas of state, tribal, and county government. We received a similar presentation on tribal sovereignty with Tad Johnson from the University of Minnesota. But this month was really our first time that we dove into a specific program or topic area, which was interesting. We talked about the opioid settlements and how the state tribal governments and county governments are involved in that work, and really talked through the desire for more intergovernment collaboration on how those funds are allocated to ensure that we're able to leverage the funds to really increase impact and address disparities, especially within American Indian communities who have been most disproportionately impacted by the opioid epidemic. So I'm excited to be involved in that group and to just be inspired by leaders across the state who are really working hard to improve working relationships across governments. Lastly, wanted to share a brief update that our legislative section kicked off in the last week of January. In the first weeks of session, both the governor and Minnesota Department of Human Services released budget proposals. Last week, the Health and Human Services committees discussed a bill that would reestablish some of the program waivers that were put in place during the pandemic to increase flexibility for how services are delivered. You heard from Julie this morning, it is not ideal to provide services to do visits via phone or teleconference, but ensuring that flexibility is built in if there are any health safety considerations for the person or family being served or for the staff. And I'll continue to bring updates about what's happening at the Capitol in future PHHS board meetings to keep you appraised of what's happening as it relates to some of the Association of Minnesota County priorities and priorities for both our public health and human services directors associations. Also wanted to offer a reminder that Wednesday, tomorrow, is the Regional Children's Mental Health Summit being hosted by the Arrowhead Behavioral Health Initiative and the Children's Cabinet. There are quite a few staff and providers within Cook County and Grand Portage who are registered to attend and participate in that. So I think it'll be a good discussion. Looking forward to that tomorrow. And wanted to spend the rest of my report talking through what we're doing within the Public Health and Human Services Department to address gaps in behavioral health care and services, provide some context of where we are, what it is we're trying to achieve, where we're headed into 2022 and beyond. I'll give a bit of an overview of some roles and definitions within the mental health system and an overview of those primary initiatives for 2022, including that addition of a mental health practitioner and coordinated response pilot. Some of this information will look familiar as I presented it in April of last year, but it's good to have a refresher. So this is an image created by the Department of Human Services that illustrates the continuum of care for mental health services for adults and children, starting on the lower end intervention with outpatient therapy, moving up towards hospitalization. And we'll use this to guide some of our discussion about what we're seeing with gaps locally, how we've responded, and where gaps remain. So in the past, a wide array of mental health services were provided locally by the Human Development Center in Cook County. Those services included therapy, therapeutic skills that were provided by a mental health practitioner, and therapy services that were provided by a licensed professional. Again, I'll get a bit into definitions as I move on. With the departure of HDC from Cook County in late 2019, this left major gaps in services. Staffing was a challenge for HDC leading up to their closure and a primary factor in their closure of the Grand Marais office. So it's been a number of years since we've had a fully staffed community mental health clinic in Cook County. Over the last several years, PHHS, as well as others in Cook County and Grand Portage, have worked to address the gaps in behavioral health care. Sawtooth Mountain Clinic has expanded access to therapy services by adding additional behavioral health consultants. Grand Portage Human Services has added mental health staff. And Public Health and Human Services, a couple of years ago, added a new position, a community support worker, to provide some of this community-based mental health care. Matthew Baxley was hired into that position. And when Matthew resigned last year, we reconfigured that position to include children's mental health case management and have that position focus mostly on skills and community-based mental health services for younger members of the community. Ascend Services, which is a for-profit agency, was able to fill some of those gaps as well, especially with some of that skills community-based mental health services. They were also the recipient of the School-Linked Mental Health Grant, which provided funding to support school-based mental health services. In addition, staff at Ascend provided therapy services, diagnostic assessments, and therapeutic skills services, as I mentioned. The pandemic, as we heard from Grace this morning, as I'm sure is on many of your radars, is really increasing the number of children and adults struggling with mental health. And the workforce shortages we're experiencing locally are happening across the state and impacting the already fragile mental health system on all areas of that continuum. Going to go over a few roles and definitions. Diagnostic assessment is really the foundation of service delivery for people struggling with mental illness and is a requirement for reimbursement through Minnesota healthcare programs. The diagnostic assessment identifies a diagnosis and recommended services, and whether or not someone meets criteria for a mental health disorder. It's the basis for someone's treatment plan, and it can only be made by a licensed provider. It's really the first step for both adults and children for effective therapy, billing, and service delivery. Diagnostic assessment must be conducted by a mental health provider. So that's a licensed professional, often a licensed independent clinical social worker. In Cook County, there are several providers of therapy services in private practice and through Sawtooth Mountain Clinic. Public Health and Human Services contracts with Sawtooth Mountain Clinic for clinical supervision of our licensed case management staff. This is a required component of service delivery and billing for the targeted case management provided by our children's and adult mental health case managers. The role of a case manager is to complete a functional assessment and level of care assessment with individuals to determine how to assist them in their recovery. We have one adult mental health case manager on staff and 2 children's mental health case managers employed through PHHS. Mental health practitioner provides community support for developing skills that support recovery and are provided by mental health practitioners. These are individuals who often have a bachelor's degree and 2,000 hours of supervised work experience working with children or adults. Again, supervision is a required component for this type of work and must be provided by a licensed professional. In order to bill for these services, an agency must be certified by the Department of Human Services to assure that the program has the proper level of oversight and supervision to provide services. And once certified, an agency can bill DHS for services and be reimbursed. Just a summary of what we're working on this year related to behavioral health and expansion of services is the addition of a mental health practitioner. In our 2022 department budget, we're asking for this board's approval to move forward with posting for that position, contingent on personnel committee review and job evaluation scoring. A required component, as I said, is that mental health practitioner receive clinical supervision. Those clinical supervision requirements can vary based on the service provided and the education, training, and experience of the practitioner hired into that position. Currently, Sawtooth Mountain Clinic provides clinical supervision of our case management staff, But in conversation with Kate, this isn't something that they have capacity to expand beyond the service that they're currently providing. So we are exploring other options for contracting out that clinical supervision component. We had a planning meeting with all of the staff within the behavioral health team in PHHS. We brought in Barb Caskey, who is a staff with Arrowhead Behavioral Health Initiative, and was able to provide that planning perspective, that outside view, and help us work through our strategies for moving this plan forward in 2022. What are the needs and requirements for clinical supervision? How can we enhance that? How are those changing based on the addition of this new staff person? And that was a really beneficial exercise for Grace and Martina and I to all be a part of and get some, again, outside facilitation and perspective. An additional initiative that we're moving forward in 2022 is the Coordinated Response Pilot. This is, again, another significant gap following the closure of HDC, is that we no longer have an entity certified to provide daytime crisis response in Cook County. After-hours crisis response and on the weekends is provided by HDC, who holds the regional contract and locally in Cook County for that after-hours mobile crisis response. There's the regional behavioral health line that is provided as a 24/7 resource, and that is the referral and entry point for after-hours and weekends crisis response. Over the last few years following the closure of HDC, that daytime crisis response has fallen really across systems to Human Services here in Cook County, Grand Portage, law enforcement oftentimes, and the emergency room. Something that we've been working on over the last few years is Grace has been convening a multidisciplinary team of professionals across systems in Cook County and Grand Portage to talk about crisis response, how we work together, develop that shared understanding of access points, workflows, systems, really reinforcing and promoting the regional resources that we have available here in Cook County, and developing that shared understanding of how, in lack of a formal daytime crisis responder, we can work most effectively together. With the support of funds through the American Rescue Plan, through the county's allocation, and through our regional mental health initiative, we have also requested pilot funds to develop a coordinated response system by embedding a mental health worker within some of these frontline areas, including law enforcement and the emergency room, by bringing on someone at that practitioner or social work level who can be that primary point of contact in responding to crises, primarily during the daytime hours when we don't have that after hours and weekend resource available, but also acting as a bridge between the daytime and the evening when there is currently a gap and no one is able to respond. Where we're at in that project is that we have been working with HDC as a primary partner with the vision of having HDC hire that individual to be embedded within these systems locally. This is modeled after other communities in the region, including Cloquet, where HDC employs and provides the oversight and supervision of an embedded social worker. Something that we are finding in moving this process forward through the contracting phase is that entry wage for this individual is a real and serious barrier for our ability to hire someone. HDC's starting wage for this type of position is just not competitive locally. Their starting wage is about $18 an hour, whereas a social worker coming in PHHS would be earning closer to $24, $25 an hour. So we're concerned about the ability to be successful in this project if we aren't able to bring someone in at a competitive wage. We have heard recently from HDC leadership that they really don't have flexibility on this, and that their recommendation is that we hire as a county position or as a independent contractor. We are, at this point, we need to bring local partners together to talk about what our options are, and that's really where we're at. We were scheduled to meet late last week, and it didn't work for a number of reasons. So we are reevaluating our options for this project. Still optimistic that we can make something work with the support of these funds, the commitment of local partners and regional resources to again provide that clinical supervision and oversight component. So as I mentioned earlier, we convened the behavioral health team with the support of Barb Caskey to review what it is we're trying to achieve, discuss unmet needs, the expansion of clinical supervision needs, and getting input from staff on what their perspectives and needs are as we continue to move this forward. Some of the key takeaways from that discussion were around revisiting the reorganization of our children and family services team, something that we introduced last spring at the point that we had learned that Ascend was leaving the community and that we needed to do something quickly to be responsive to meet these gaps. So this is something that we are seriously considering and revisiting while we move forward in filling the practitioner level position, getting the clinical supervision in place for that new position, and continuing to develop the coordinated response pilot. I know that's a lot of information to share. I have Grace here, Children and Family Services Supervisor, who currently oversees all of the behavioral health staff within the department to be able to address more questions and provide perspective. Again, we don't have an ask associated with this proposed reorganization today, just reintroducing this as something that we're seriously revisiting as a way to help move some of these really big initiatives forward that we're undertaking. Just to summarize what it is we're trying to do is that we're really trying to replicate the services that would be provided in any other community by a community mental health clinic. There are a lot of requirements involved in that and not something that we're currently set up with as a department. We have taken steps to integrate some of these roles within our team, and that just isn't sustainable. We are seeing staff with consistent overtime. It's challenging from a leadership standpoint to keep tabs on all of these various initiatives and keep things moving forward, especially when it involves a lot of coordination across systems. Ideally, HDC, Ascend, another mental health provider would open a facility in Cook County, open a clinic, provide an array of services. We just don't see that happening anytime soon. We have, over the last few years since HDC closed, worked to integrate these services within our department to be responsive, to stay connected with other local partners who are working to address gaps. But just given where we're at in the pandemic and the recovery phase, really feel like now's the time to move forward with some of these more drastic changes. Grace, when we discussed this with the local mental health advisory council last week, when we met to preview what we were talking about revisiting this proposal, and Grace had a really great analogy of the Sawtooth Mountain Clinic and how several years ago they probably didn't have within their strategic plan or vision to open an in-house pharmacy, but we lost 2 pharmacy providers in the community. They were able to be responsive and fill that really acute gap locally. We're at a similar place right now with mental health services. So again, short-term next steps, filling the skills position, getting that short-term clinical supervision in place, and then in the midterm, exploring that reorganization of the Children and Family Services unit. An opportunity there is that we could hire someone to provide day-to-day supervision of that team who also has the licensure and ability to provide clinical supervision, to bring that expense in-house, not have to contract it. And there are a variety of reasons why that would be a strength for the team. We need to do more engagement with local partners in talking about our vision, what it is we're trying to achieve, ensuring that we have support, and of course providing a budget estimate for this board to consider looking at our revenue opportunities, the expenses, what that would look like for the addition of another supervisory staff within the department. I'm confident that we have the data to support the need, but it's just a matter of pulling that all together. So it's one of the questions that I have for you all this morning is what type of information would be most helpful for you to consider a future request. Obviously things like the budget impact, revenue, current staff, overtime, and some of our assumptions on billable services. But if there are other factors that would be valuable for you all to consider that request, please let me know.
Thank you. What do you think, Board? What other factors? Yeah, Commissioner
Well, I'd
Sullivan.
just like to express my appreciation and gratitude for all the work, the flexibility, the creativity that your department has demonstrated in responding to our residents' needs, and I just want to thank you for that.
Commissioner Hawkins, yeah.
Yeah, thank you. And I do know the mental health needs in our community are rising. I mean, this pandemic has caused some of that, so I think it is important that we address that. We try to come up with a plan to make sure we're providing services that people need. I want to go back to the certification so that we can get reimbursement from DHS, because we've been talking about this for a while now. So where are we in that process of making sure we get that certification?
So we are at the point that we've started integrating some of those skill-based services within our case management positions, because without an entity to refer out to, the staff are having to provide that in addition to case management, and that is a challenge for staff to act in both roles and provide continuity of care. We have not achieved certification through DHS because we just haven't had the time and capacity to really pursue that. We need the clinical supervision in place, which we currently have for our mental health case managers, but not for the practitioner level staff. As we've moved forward with just integrating that in, we haven't dedicated resources to providing that service. Like Matthew Baxley, in his role as community support provider, was providing that in a more universal basis to people who are maybe seeking a diagnosis, don't have a billable service. So we were able to access some state grants to support his position. But the ARMS certification is something that, yes, has been an ongoing need and something that we haven't achieved to date. This is where we could lean on the support of HDC or other entities in the region that are already certified and licensed to provide this level of service.
Am I understanding it right that we need the clinical supervision contract before we can get that reimbursement?
That's a key component of the reimbursement
and so,
piece, yes.
In my memory is when we talked about this before, is we kind of, there was kind of a community shock to services being pulled out, and we were looking to fill that in, but then we thought, okay, we better take this step by step and slow, and then that's where the services were tried to integrate into current staff case management. And then now here we are after the meeting with Barb, kind of revisiting, okay, we need to start taking these steps. Is that an accurate summary?
Yes, absolutely. And just recognizing that we need support in achieving that certification, that the guidance of a mental health provider or another county entity that's providing this service. And that's something that we could request, perhaps, as we seek out the clinical supervision, is that would include some technical assistance from an agency or provider that is currently billing for this service to help us with all of the medical records, the billing, the documentation, all of the required components that we would need to seek DHS revenue for the service or bill health plans for the service.
Well, and the other question I would have too is in your conversation, and this might be a stretch, but in your conversations with the clinic, they do not have the capacity for the clinical supervision, which I understand. And I guess I could have asked this a while ago too, but there's also no plans to expand their capacity in that way. Is that accurate?
Not that I'm aware of.
Yeah.
When I was meeting with Kate late in the year to develop our contracts for 2022, we posed the question about this additional need for clinical supervision for this practitioner level position. And she said that, they're able to continue to provide the clinical supervision for case managers, but wouldn't have capacity to expand beyond that at this point.
Yeah.
So again, confirming these assumptions
Yep.
is a part of my next steps
Yep.
in developing the proposal.
Yeah, please.
And I'm sorry, sometimes when you talk, it's like goes way over my head because I just don't have the background. So it's going to make me sound like didn't get anything you said. So, of course, my thing is I want to be responsible with dollars, and I hear DHS reimbursement, and I'm wondering, well, we certainly can use that to offset whatever our costs are. But then you talk about another position to make that happen. Did I hear that?
Yeah.
And how does that work? And
Yeah.
is the reimbursement worth it?
Yeah, I think Grace has a comment. Do you want to come up to the mic, Grace?
I would love to, because I agree, Stacy. We have been talking about reimbursement and certification for a really long time, and we ourselves are frustrated that it hasn't taken off. But you are correct. As we dug into the rules, which are set by the federal government for reimbursement and interpreted by the state and managed by the state, we just needed to meet a certain level of criteria of staffing that we just don't have. And we just don't have the capacity in the county to have that on the regular basis so that we're ethically and legally in alignment with accessing medical assistance reimbursement. So that has been our stumbling block, and I think Commissioner Mills is right, that we have been looking for this. We did want to see if we could patchwork it together, but it's not an effective system for providing continuity of care for people. People need ongoing care. They need and our team needs ongoing supervision in order to maintain them. So yes, we do need we need a position that is of a person who's certified as a mental health professional, which is a title that is defined by the state of Minnesota that requires a certain level of licensure and credentialing. And so in order for us to provide, to supervise and get reimbursement. So you heard it correctly. It's called the golden thread. You have to have that mental health professional who can guide the case managers, who can guide the practitioners, so that we can access the medical assistance reimbursement. So those are rules that we must follow. So,
Mr. Chair.
Please,
So
Commissioner
what I'm
Sullivan.
hearing you say, Grace, is that this is one step that we need to take.
that is the key step.
I understand that, but there are other steps that we need to take, and I believe that's what I'm missing. The whole picture hasn't been laid out. If the goal is, and I'm not saying it is, but if the goal is to actually get the DHS reimbursement, it would be much easier for us if we just laid out, this is the staffing positions we would need, this is the whole picture that we would need, or is this it? If you had this person right now, would you be able to?
I think we also need the clinical supervision contract.
I understand that, and that's what we just discussed. That's the golden thread, and that's what they're asking for. I want to know what else we need.
Oh, I'm sorry, go ahead.
Thank you for that question. If we have that mental health professional, we do have people providing targeted case management.
Yep.
That mental health professional could supervise that person versus the contracted person.
Right.
That mental health professional could supervise the skills worker, and we could draw down that reimbursement. So with that key position, the other positions would, I think we're right on this, that we already have the case managers, we have the positions for the outreach people. So that's the key position to make this whole thing work in a most effective way.
And our short-term step is to fill the current vacancy that we have in the department budget, get short-term clinical supervision, while we continue to develop what this would look like to have a more comprehensive mental health team with a professional on staff providing the clinical supervision in-house. That's not something we're asking for today, but reintroducing as what we feel like is really the best path forward for our department in meeting up needs in Cook County.
So
Anna, yeah.
could you just simplify it by saying you'd be hiring a new person, you'd have to pay that person, but you'd be, through that hiring, you would be getting money back, which would more than cover their salary and would cover what you're now paying to other places to get the supervision piecemeal. Is
Not
that right?
fully offset, but there would be
Not totally offset, but help.
Another opportunity for that position is that they could conduct diagnostic assessments, which is, as we shared, a foundation of mental health service delivery, something that we're able to get locally from providers at the clinic and from regional resources, but again, a strength in having that in-house.
Yeah, and that's a billable service as well.
Exactly. Thanks, Grace.
So there's many layers to this and many hoops and many steps. And so I feel like you laid it out fairly well, but what you're asking for from us right now is what else do we need to better understand how this works and what data would help make the case for this as well? Is that accurate?
Yes.
So are there things that would help us better understand this? A picture might help me. For a future meeting, not right now by any means, but just having that visual structure, I think is helpful for me.
I think it would be for me too. It's
Yeah.
just, that's all I'm looking at is this is what would be required, this is what we have, this is where things line up, and here's where our gaps are.
Yep.
That's all.
Yeah. But I think you already identified some good data points, Alice, and that would be helpful. And also just our needs. I don't know how you can figure that, I don't know how you can assess that data, but yeah, please, Pat.
Can you quantify it at all, Allison, as far as the need we're currently needing and the need you think that's out there?
It's really
Need for what? I'm sorry, what need for volume of service or?
Well,
Yeah.
yeah, I guess that's the way I'd put it.
It's challenging because we haven't had a robust level of service for many, many years.
Yeah.
We have, as I shared, added staff within the department. Other entities in the community have added staff. Still, we're experiencing overtime within the PHHS team when staff are wearing multiple hats, trying to provide case management and skills work. That's one of the data points that we will share, but to accurately quantify the level of need in the community is really difficult given how under-resourced we've been for such a long time and how needs are increasing. Grace, would you add anything to that?
No, it's really a good point that, so example, one of our positions, Anna Ross, provides case management. And in most communities, a case manager is somebody who says, I'm going to refer you to X resource and Y resource. And then that person just makes sure, did you get with that resource? Since we don't have those resources, you're kind of referring to yourself, like, oh, you need budgeting help? Well, I guess we can meet Thursday at 3. Oh, you need skills in managing your moods. Okay, well, I guess I'll have to provide that because we don't have any other service providers. So it's very bundled and multi-layered, and as compared to even like Lake County, they don't in-house in their county, they don't even provide targeted case management. They contract with another organization to provide it. So we just don't have the opportunities because we have such a scarcity of resource. We really are a desert of resources for humans who are stressed, and we are all living in chronic stress right now, and we're really seeing it daily, more and more people being referred, calls from the emergency room, calls from the hospital, calls from law enforcement. So not to make too fine of a point on it, but we need to think about this differently because it's not going to resolve quickly.
Yeah.
It's going to be.
All of these things you just talked about can be quantified. How many calls are you getting? Those kinds of things. Even if it's a little bit of data,
Yep.
I think that's the kind of data that really helps us
Exactly right.
then say, if it's happening here, we all understand that it's probably bigger and we're just not seeing it yet. So that kind of data does help too.
That's
Yeah,
probably
we're
the
seeing it
hardest.
when it's a breakthrough type of thing, where it's at the hospital, law enforcement, or these others, and, you know what I mean? So, if you, to Pat's point, if you had that data, you would know, at least at that threshold. We
Yeah.
would like to be able to deal with it before that, obviously. But at least if we had that data, that would give us some
Sure.
idea. And I'm not saying that you've recorded everyone, I don't know, but I mean, whatever availability you have of that type of data would be compelling for me.
Yes, and just to speak to that one person, for example, in December, we had we working really closely with the hospital and law enforcement, and that one individual's encounter took a couple of weeks, and I don't know how many hours, so
Yep.
the number one could mean 200 hours.
I know.
Yeah.
And so, just to clarify, okay, thank you,
I'm
just
aware
wanted to
of that.
make sure.
Yep.
All right. Well, if other things come to mind for what we would be looking at or what we'd be asking for, please pass them on to Allison to help better kind of build this case and look at it from as many different angles and possibilities as possible. And that'll just help the organization and department as well. So, and us, for that matter, it'll help us making these decisions with, especially the longer term ones too, potential restructuring, you know, it's all going to be factors there. But clearly we're running short on time here, and we still have, if we're through with item 6, we can move on to item 7, the items for board action. We've got 2 of them there, and reimbursement for staff training. We've had some discussion there, as well as the approval for the posting of the mental health practitioner. We just had some discussion around that a little bit too. Starting with the first one, item A. More discussion or further thoughts? Is there, Commissioner Hawkins, you brought up some good questions. I didn't know if that raised any hesitancy from you, Allison, or from you, James, if we want to table this, or if we want to move ahead with it. We're talking about 7A, the staff reimbursement item for action.
I guess what I would say about that is we will move forward with developing that policy sooner rather than later. I think it's really up to the board. I mean, I would like it to be considered today, but if you all don't have a comfort level with that, it could be deferred.
Yeah. My biggest discomfort was kind of that tax issue, and it sounds like that got cleared up. I want to do as much as we can to support staff, and so that's where my inkling is to go forward with this. But I do want to hear what everyone else has to say, and also the point about having to go to the straight up county board. If we're following our policies, then what we can do is, as this board, recommend it to the county board, and we'll see what the county board has to do with it. You had your hand up, Commissioner
I did.
Svaleson.
I've been taking on all of this, and very good points were made in the discussion, and I think that's because of the lack of policy that's currently there. And so good discussion on that. I do think it's appropriate. I do find that those policies give you the equity amongst all folks. It takes away that thing of somebody saying, well, so-and-so's getting this. Well, obviously, if you chose to go and pursue that type of thing, then you could enjoy that as well, as long as you're clear as far as your budgeting and all those things as you move forward. I look at this as that's a going forward type of thing. The question today is, are we going to pay these 2 people? The money was already budgeted. The money was sitting there, not specifically for this, but it was for training and for travel. it's available, and I don't see a reason why not to, move forward with it today.
Well, I see lots
Just
of.
one opinion.
Yeah, well, I saw lots of nodding.
And
And a little shaking, and a little shaking.
Just gotta get that in there.
Mr. Chair, let me be more specific. I would make a motion to approve the reimbursement for the staff training that has been requested.
And I would support that motion.
Thank you, Commissioner Svaleson. Commissioner Sullivan, we have a motion and support. Further discussion, Pat, you had your hand up?
I was going to say, I don't think this is an either-or. This is a
Right,
both-and
yeah,
kind of
right.
thing. There is money in the budget. These people did act, I think, in a responsible manner in the way they proposed this to us. And so I am with Commissioner Sullivan and Svaleson about the fact that this should go forward.
Thank you, Pat. And yes, do you have further discussion, Commissioner Hawkins?
Well, I will just go on the record saying, my reason will be voting no is because I think we need to follow policy. Our current policy doesn't state it that this board can vote on it. I really think we need a clear-cut policy. That is the job of elected officials, is to make policy and follow policy. So I just want to give clarification when I vote no.
And my question, I guess, please go ahead, Pat.
Well, I'm really new to this, so I have to ask Stacy a question. Doesn't this board vote on these kinds of things all the time?
Well, this board, I guess, yeah, typically does vote on departmental budgeting, and so I guess this does fall in it. The catch is, to Commissioner Hawkins' point, that the current policy is there, though quite vague, but does say specifically the Cook County Board. And so we can, as the Public Health and Human Services Board, pass this on to the county board, and again, we'll see what they have to say about it, those guys.
Isn't there the same people as the county board here now?
Similar, it's a similar makeup, but a different legal makeup.
And we have additional members that would be voting, that wouldn't be voting during that time period.
And that's, I'm sorry, you can't see my tongue in my cheek with my mask on. That's what I was getting at, is it's going to be a similar outcome, but it is, to Commissioner Hawkins' point, very important that we follow process and the current policies, so. And so that's what my question is was your motion, Commissioner Svaleson, intention to bring it on to the county board? Is that, or?
My intention was to vote on it here as this particular board.
Okay.
And because it's already approved in the 2021 budget by this, not only this committee, but the Cook County Board of Commissioners approved that budget. And the money is being spent for the target of what it was designed to be spent on. And we're hanging up on one policy issue that we need to correct that policy, and we will.
Thank you.
And I will bring it up at the Personnel Committee today.
It's a great thing to do.
Absolutely.
Very good. Well, I'll get to talk more about that then. I'm excited. Any further discussion here now? Else, all in favor?
Aye.
Opposed?
Nay.
And motion passes 6-1. Thank you. And moving on to item 7B, approval to post for mental health practitioner. Any further discussion there, or any more questions there about where this fits in our steps? Commissioner Svaleson?
No more questions. I appreciate the conversation. I appreciate the clarification. It helped me out, and I hope we've given you good feedback on the types of things that might help us to go, build that program that you see in the future. I mean, that's, I think, the right way to go for our community. I don't see that we really have a lot of options, since we can't seem to attract the type of talent and resources that we need in the community. With that said, Mr. Chair, I would make a motion to approve to post for the mental health practitioner.
Thank you, Commissioner Sullivan. We have a motion. Is there support?
Storlie, support.
Thank you, Commissioner Storlie. We have a motion and support. Any further discussion? Commissioner Hawkins?
I just have one more thing. This is a process thing too, that we are approving something based on the Personnel Committee, which is meeting today.
Mm-hmm.
So they could meet and discuss. They might have more input. And then it could come before the county board on Tuesday. in the consent agenda and have it be more apparent that we all get to see the job description that they approved and the grading. So I just have no, this is a needed position, not against the position. I'm against the process and the way it's being handled, so.
Commissioner Svaleson.
And my comment to that would be, we're going to get to see that as the Cook County Board of Commissioners and have a choice to approve or disapprove the level that they choose to put this at.
That's not how I read this, so I could be wrong. All right.
Right, I mean, don't those always come before the board when the personnel committee?
Yeah, and I think what Commissioner Hawkins is saying is just that the timing of it is difficult, and so it could have gone through personnel grading, we could see it, then it comes here.
But I think we're getting caught up in the, that timing piece, and what I think is true is that even if we approve this today so that they then have the approval they need to be able to move forward from that perspective, once the personnel committee meets, that'll cycle back through us, and the question as to the level that's being set, we'll have that review as commissioners.
But the request is to post it as soon as after review of the personnel committee. That's how I'm reading this, which means it won't come, if they have the authority to post it tomorrow morning, the county board isn't going to approve that job description because they have to post the job, right? Explain where I'm thinking wrong here.
Administrator Yoki, please.
Could I ask a clarifying question? So I think part of the issue here is we want to move forward with posting this because time is of the essence, right? I mean, the sooner we can get this filled, the better. My question would be, if the board does need to approve the grading of the position, are we going to go ahead and post it without that information in the interim, and then after that's approved, come back and add that in, or how are we going to handle that?
My intent is to post it following the job evaluation committee review and scoring of the position. So once the personnel committee has had a chance to review and weigh in, once the job evaluation committee has had a chance to review and formally score and evaluate the grade for that position, that's the point at which we would begin recruitment. I would anticipate that would happen sometime in the next couple weeks.
Mm-hmm.
I'm confident at the grade that we have estimated for this position. I don't expect any unanticipated budgetary impacts, but I wouldn't want to post it and learn that the wage is changing. That's an important recruitment tool, so that would be a primary factor in having that confirmed by the evaluation committee before beginning recruitment for the position.
And won't that be happening this week? I mean, are we
Well,
saying
we
it
may not?
The personnel committee will be happening. The evaluation, I have
That can
not
take a
my
couple of
fingers on.
weeks.
Yeah.
So if you're going to wait to post before that, it can still come before a county board meeting, is what I'm saying. It's the process of things getting done ahead of time that's not available to other departments. That's what I'm looking at it that way. No other department gets to have a board pre-approve something before the county board. No.
Aren't we just approving that we, as has been a long presentation of lots of information, we need this? We're saying, yes, we really need this?
That's not
Because
how I
then
interpret
that's
that.
going to the board, and whoever's new on there won't have heard all of this because they weren't there, but they can respect our evaluation that, yes, we agree we need it. You know, does that make sense, or is that not? I mean, we're obviously not hiring anybody today. We don't, we're not actually, it's not written already to be put in the paper this week. It's still going in process and would still need to be approved by these other ones, but we're just giving our support to it as a people who work with that, who hear about this issue,
So if the motion is to approve sending this on to the county board for their approval, we support it. Oh, I can support that. If we are saying, no, we are we're giving approval to post this position based only on the Personnel Committee and the Job Description Committee, I have a problem with that wording.
I hear you.
That's, it's back to procedure and policy and making sure we always do it the same way for everybody, and we don't make different rules for different departments.
Yeah, I hear your concerns. I don't know, what I'm weighing is, the acute need, and having gone through this board, has some strength in my mind versus just, and hamstringing is too strong of a word, but, slowing down the process to fill this need is my concern, but depending on how staff feels about it, if it's not hurting, our, addressing our needs by having it go back to the county board, I think that's probably a better way to cross all the Ts and dot all the Is. So just, I don't know if that's going to delay it by weeks or not at all, or how that works. So I'm going to rely on staff thinking there. Not being involved in that job evaluation process and, yeah.
Yeah, well, it'll be a new process now with our new HR director
True.
in her role. So I'm anticipating that job evaluation will be scheduled in the next week or two. I haven't, Leah hasn't sent out an invite or scheduled that yet. It's not uncommon for us to do this type of request contingent on board or personnel committee approval. We've done it in the past.
Yeah.
I understand and respect the position of both of you commissioners in wanting to follow process. It feels a bit like an extra step.
That's my concern.
But I can understand why you would want us to delay until the position has been formally approved. I don't have any concerns with that. It's not typical that our personnel committee or a job evaluation committee has a drastically different read on the position or the evaluation that are assuming for the position.
Yeah, no, that helps me. Thank you. I just had concerns about timing, and I think that I'm comfortable with the current motion myself.
Repeat the motion again. Do you have that? What is the actual motion again?
I believe Commissioner Svaleson read just the recommendation there. So approval to post for mental health practitioner posting pending personnel committee review and job evaluation.
Okay.
Isn't that including what you're looking for in the process?
Well, I think Commissioner Hawkins' concerns are going back to the county board again.
Yeah.
Yeah.
Okay.
But
Isn't that still presented to the board though at some point?
it is after it's been posted. So
okay.
that's, I potentially, that's the concern, but,
Okay. 'Cause we serve to provide information to the full
Yeah.
board because they wouldn't be able to do all this just alone, you know? It's too much.
well, and, yeah, and, how strictly we adhere to policy, I think there's the practical side of that as well. And in this case, I don't see a practical risk. So that's why I kind of just want to do what we can to meet this acute need as best we can, so.
Don't you have commissioners have the ultimate hammer anyway? If you don't like it, you can say no.
Right, yeah.
That's kind of what I was saying, yeah.
So, okay, we've had a very thorough conversation both earlier and now. So thank you for your further input, and we have a motion and support on the table. Any further discussion here? All those in favor? Aye. Opposed?
Nay.
A motion passes 6-1, and that is it for our board action. And considering where we are with time, I wonder if the board would be open to delaying our committee reports if there's something
Mr. Chair,
pressing.
I would move that we not do our board updates or the committee updates for today's meeting.
Thank you, Commissioner Svaleson. We have a motion. Is there support?
Support.
Thank you, Commissioner Hawkins. Motion support. Any further discussion? If there's something pressing, please send an email to either Allison or James, and then they can distribute it to us as need be. All those in favor? Aye. That brings us down to the last item, adjournment. Entertain a motion there.
I will make the motion to adjourn.
Thank you, Commissioner Hawkins. Is there support?
I will support.
Thank you, Commissioner Svaleson. We are adjourned. Thank you.
You have a report
You
on
have
economic
as long a meeting as I
activity in the
did.
county? I'm sorry. I was looking at your pile of stuff.
Yeah,
What
Fair
that
is fair,
from?
huh?
It's a presentation.
it's today, so I don't know. Yes, that's from ARDC, and I asked him to come and